Thank you, Sudhir. It is a pleasure and an honor to be back. I attended this conference and many conferences across the street when I was a resident. And so actually to be giving this talk in front of many of my mentors is really an honor for me. I hope the fact I haven't slept in 3 days doesn't affect my delivery, but if it does, you'll have a copy of the slides in your handout, and hopefully I can decipher some of them for you when I've had some rest. My topic this morning is DALK. Is the big bubble worth the trouble? And the question that Sudhir posed earlier showed that over 50% of respondents said not doing DALK yet, but interested. And I think there was about 17% or so said not going to do it because of my unstable angina. This talk is really for that two-thirds of the audience then who's not doing DALK to try to convince you should be doing this as soon as you return home to your practices. By way of disclosure, I have no financial interest in DALK surgery other than the fact it pays my rent, so I guess I do. But none of the products I mentioned, I will mention in this presentation, do I have a financial interest in. I want to start with a presentation of a case. This is a 53-year-old gentleman who had hexagonal keratotomy OU 25 years ago. And for the younger folks in the audience, which I'm one, XK is an older treatment done for management of hyperopia. There's a surgeon in Glendale, which is a suburb of Los Angeles, who published a series of over 480 cases of hexagonal keratotomy. So we see a lot of these patients in LA. This gentleman had been fit with rigid experimental contact lenses and piggyback lenses, but continued to be bothered by glare, so was referred to me by a corneal transplant surgeon, bad sign, for corneal transplantation. So here you can see the HexK incisions. Looks like Jack wanted me to use the mouse, but the mouse doesn't look like it's working, so I'll point out with a laser. You can see them clearly here with a fairly small optical zone and two astigmatic keratotomy incisions thrown in to boot. Same thing here. This central area showed significant ectasia, which showed up on the topography with a steepest value here of 81 diopters. So the central cornea looks like a muffin top sticking out of the center of his cornea. It's a miracle this man put up with the quality of this vision for as long as he did. So I decided to do a femtosecond assisted DALK for this patient. And Jack, again, if this mouse doesn't seem to be working, if you can click on,
there you go.
There we go, woke it up. So here we see, very important, Brandon just mentioned about centration with the femtosecond laser making intact channels. With femtokeratoplasty, very important centration, and it is a little difficult to tell underneath the laser, so always make a central mark. This is a zigzag edge profile, so you just saw the ring lamellar cut coming in. This is the anterior side cut coming up. For those who don't do femtokeratoplasty, once you see that air breakthrough, that means you're done cutting through the patient's cornea. You can relax, and you just make these alignment marks. This whole treatment with the laser that we have takes about 2.5 minutes with a 60 kilohertz version. Here are a little too many bubbles in the anterior chamber, but once we get the big bubble, you'll see these bubbles be pushed out to the angle. This is the so-called double bubble sign. There you see them. So that if you have too much emphysema centrally, you can still determine whether you have a big bubble or not. Surgeons do this differently. I like to remove the anterior stroma after I have created a big bubble. And then, Sudhir, I hear your voice every time I make that brave slash, thinking don't go too deep. Now we're entering that space that was created with the air between the posterior stroma and descemet's membrane. Use a typical divide and conquer technique to remove the remaining posterior stroma. These are using the Fogla scissors. What's nice about this zigzag profile is that you can hold the scissors at an angle rather than perpendicular to cut the remaining posterior stroma. I think it gives you a little greater safety margin. The donor cornea, of course, has the endothelium stripped off, and then you'll notice perfect matching of the donor and the host. One of the big advantages of using the femtosecond laser for DALK, using this zigzag profile, is you'll get perfect matching of the donor and host. There's no step, even if you do leave a little bit of host stromal tissue along the edge of the trephination. So here's the patient at the slit lamp. This is 1 month after surgery. Again, Jack, if you can click on that video for me. Thank you. Again, another reason to do DALK, very rapid corneal deturgescence. You see a thin, compact cornea just 4 weeks after surgery. And for those who doubt whether you can get a good interdigitation of the zig and the zag, you can see it right there. In every case for which I performed the zigzag edge cut for femtokeratoplasty, you'll see that perfect interdigitation of the donor and the host. Again, always with very good matching of the surface contour. So in this case, at 1 month, we see topography shows a relatively even profile with 1.3 diopters of astigmatism, and then at 3 months, had under a diopter. So in this case, left all sutures in. So when we're looking at the results, I'll show them to you a little bit later, another talk regarding femtokeratoplasty versus manual keratoplasty. A lot of people want to see what's the topography look like, all sutures out. Well, keep in mind, in your best results like this one, the one I'm, of course, going to show you, many times you leave all sutures in. And so it's really difficult in some ways to assess the efficacy of the femtosecond laser versus manual techniques for performing trephination. But that's the subject of a talk this afternoon. With this talk, we want to look at, is DALK worth the trouble? And there is an investment as far as time and expense. And then we have to weigh that, of course, against the return. So as far as expense, well, it doesn't take much to do DALK. And so when I go to different countries and train surgeons to perform DALK, I'm a very generous guy. I take all the instruments that are needed to help them get started. It usually costs me about $400, if that. Helps to have something like this. This is the Fogler cannula. It's a regular 30 gauge or 27 gauge cannula with an air port on the bottom, so that when the air comes out, it's going to go downward, again facilitating dissection of Descemet's membrane from the posterior stroma. Some sort of pointy thing like this, the Fogler dissector, is often used to make the initial tract in the posterior stroma into which the cannula is then placed. It helps to have a pair of scissors, which you have a bottom blade with a rounded end, so you don't pierce Descemet's membrane with it. And I don't use this trifacet spatula. This comes with a Fogler set, but I don't find a need for that. So really all you need is a dissector, a cannula, and then right and left going scissors with a blade on the bottom that's curved. And that's all you need to perform DALK, and some time. Also, it helps to supplement your income with other procedures because you get punished financially for doing the right thing for your patients. Penetrating keratoplasty, using this code here, Medicare RVRVS, about $1,300. Lamellar keratoplasty, Medicare RVRVS, you get paid about $125 less. The average payment, looked at my payments thus far in Los Angeles from all the different insurance carriers. For penetrating keratoplasty, I'm getting about $1,600, $1,700. Average payment for lamellar keratoplasty, $500 less. So this is why my colleague Sophie Deng, she actually never told me this. I was getting some papers off the printer 2 weeks ago, and I saw an op report of hers, and it said, penetrating keratoplasty with retention of Descemet's membrane. She is so clever. So I started billing it that way. Barry Lee bills it as a big bubble penetrating keratoplasty, and he shared that at a meeting. So again, I'm not encouraging anybody to bill in anything other than an ethical manner, especially since I'm the vice chair of the ethics committee. But seriously, I think the technique we're using really is more similar to penetrating keratoplasty than what somebody envisioned when they came up with this code. So I personally am going to start billing as penetrating keratoplasty with retention of Descemet's membrane. What about time and effort? Well, there's a lot of cases like this one that I'll show you where you spend a good amount of time getting down to where you're burying Descemet's membrane. I'm at this point talking to my fellows, complimenting myself on such a nice, clean rim, saying that they should just strive to have results like this in their surgeries. And I'm telling them that this is the remaining posterior stroma. Of course, once I remove this, we'll turn our attention to the donor, strip off the endothelium. We'll be out of here in about 20 minutes. And so I'm talking again, slap myself on the back when I do something stupid, like that. So I just keep going. So I ignored that, and the fellow asked about the fluid, and I said, what fluid? Tried to reform the chamber with air, which a speaker yesterday in Manila said, Enzo said, do not do that, you're going to extend your tear. In this case, could not save it, had to convert to penetrating keratoplasty. Quite frustrating when you've spent half an hour getting down to bare Descemet's, especially if you don't get a big bubble and you perform a manual dissection only to do something stupid like that. That will certainly sour your enthusiasm for such a procedure. But hopefully these sorts of things are uncommon, and most of the time with microperforations you can still salvage a DALK. This is an article that appeared in Cornea. This is 2007 on DALK, looking at various complications, one of which is Descemet's perforation. So in this series, it's about 14%. And a lot of surgeons will quote a conversion rate somewhere around 10%, but they'll acknowledge many times that perforation rate's higher. So that many of these perforations, microperforations, can be salvaged. Enzo said yesterday at the meeting in Manila that he never, ever converts from DALK to penetrating keratoplasty. Showed some videos where he probably should have converted. But again, in this case, you see perforation in about 14%, but conversion only about 9%. So what's the return? We've seen that you get paid less for a surgery that's more technically difficult and takes more time. And so far, I don't think I'm converting any of that 50-some-odd% that said they're thinking about it but not doing it yet. Well, here's the return. Donor cornealization. This article from the group at Ames, Namrata Sharma is the first author on this, in which they described the use of 12 corneas. They performed a automated dissection, so they used the anterior stroma, which is about 300-400 microns, for ALTK, the remaining posterior corneal tissue for DSEK. Again, in the United States, we don't have the ability to use a single donor for 2 recipients, but outside the United States, this is commonly done. So the performance of lamellar procedures will allow these countries with a dearth of donor corneas to be able to use 1 cornea for 2 recipients. The same idea was published by Klaus Kurzephen and Frederick Kruz's group in Germany, this article in AJO, in which they describe the use of 50 corneas, in which they performed DMAC and DALK. So they took the corneas, split off Descemet's membrane, and then used the anterior stroma for a DLK recipient, and of course the endothelium for DMAC. And in 47 of the 50, they were able to successfully retain the recipient's Descemet's membrane, therefore being able to use the stroma from a donor. In 3 of the cases, they were not able to retain the host Descemet, so they had to convert this to penetrating keratoplasty. But in this series, they were able to save 47 cornea. So it just makes sense in countries where you have the ability to use 1 donor for 2 recipients that you are facile with techniques such as DALK and DMAC, which will greatly expand your donor cornea supply. So for donor corneas that have good endothelium, as we just saw, the group from India showed us, you can perform ALTK and DSAC, and the group from Germany showed us you can use 1 donor for both DALK and DMAC. But also keep in mind that we aren't using the donor endothelium when we're performing DALK. So if you're able to perform DALK, you're able to use those poor quality donor corneas for DALK or as a carrier for the Boston keraprosthesis. And this is huge in countries where you may have a few corneas, but the ones that you get maybe 14 days from death to surgery with a very poor endothelial cell count, as we were actually just using in Vietnam before I was in Manila. So visual outcomes. Are the visual outcomes with DALK as good as they are with penetrating keratoplasty? There's an article from Donald Tan's group at SNEC published in British Journal of Ophthalmology a few years ago looking at visual acuity, comparing penetrating keratoplasty to DALK. And here they're looking at percentage of eyes that obtain vision of 6/9 or 20/30 or better. Those having penetrating keratoplasty, about 1/3. Those having DALK, this is the manual technique, so a manual dissection down to Descemet's, not necessarily using a big bubble, about the same percent. But those who had Descemet's bearing technique of DALK, a greater percentage. So at least this paper says visual acuities with DALK are at least equivalent to those obtained with penetrating keratoplasty. This multi-center study looking at visual outcomes after DALK, again comparing the two, DALK versus penetrating keratoplasty. Of all patients having DALK, compared to all patients having penetrating keratoplasty, they actually showed, if you look at the visual acuities, that there was a significantly better visual acuity in the group having penetrating keratoplasty at 3 months and 6 months after surgery. See the p-values here. But at 12 months, there was no significant difference in the visual acuities between the 2 groups. What about postoperative complications? Well, this looked at long-term results of DALK versus penetrating keratoplasty. Here we have 142 eyes in each group, so a pretty decent-sized series. Epithelial rejection, uncommon in both groups. Subepithelial, uncommon. Stromal. Here's one of the downsides of DALK, and I've seen this in my own experience. They found 11% of eyes having DALK experience a stromal rejection versus 1% in PK. This could certainly be related to the fact that many surgeons have a tendency to taper patients off of steroids more quickly if they've had DALK, knowing they don't have to worry about endothelial rejection. Elmer Tu just gave a talk in Manila a couple of days ago in which he said his rate of stromal rejection in patients having DALK is around 20%. In my series, it's 15 to 20%, so it's certainly higher than it is with penetrating keratoplasty. It may be that the body knows there's a transplant that's occurred. It first tries to reject the endothelium when it says, oh, shoot, that's me. Then it goes on to reject the stroma. Who knows? But I would encourage all of you who are performing DALK or certainly starting to perform DALK, I would say use your steroids as you would with a penetrating keratoplasty patient, especially a young keratoconic with a good immune system, because there is certainly a higher rate of stromal rejection in patients having DALK. The big advantage are the goose eggs here. Obviously, you cannot have endothelial rejection if it's retained. There are other problems that can occur, something like double anterior chamber, unique to DALK. Fortunately, it's uncommon, and fortunately for anybody who does DSEC, who's used to using air to tamponade things against the back of the cornea, that can be addressed in most cases fairly easily. Stromal rejection is not always something that's reversible. This is a patient of mine, a 15-year-old girl for whom I performed a DALK, had a beautiful result. She was 20/25 uncorrected. Did not come back, though, for follow-up appointments. Sutures loosened, drew in vascularization and scarring. And you can see here on retral illumination against the red reflex, significant vascularization with that scarring, vision down at 2200. So now what do? Well, it's going to be almost impossible, as I found, to do another DALK. Had to perform a penetrating keratoplasty, already a large diameter graft. So now you're performing an even larger graft into a vascularized bed. So yes, she has rejected, and I've had to give her multiple subconjunctival steroid injections, and now she has posterior subcapsular cataract developing. So I would say really want to aggressively treat these patients with steroids, even if they are retaining their own endothelium. Another patient of mine with DALK, again, same thing. This gentleman uses antibiotics, uses steroids as I asked, kept his appointments, but still developed significant vascularization of the host rim, and they still developed stromal edema, interestingly enough. Again, had evidence of endothelial dysfunction, even though this was a DALK. In this case, the cornea cleared and the patient recovered good vision. And so finally, what about endothelial cell loss and graft survival? Looking here at cell loss at 1 year, comparing DALK versus penetrating keratoplasty. We look at 3 months, 6 months, and 12 months, comparing DALK to PK. We see there's not a significant difference. But this series included patients who had microperforations during DALK. So if those patients are excluded, looked only at those patients who had an intact descemetous membrane and look at the cell loss comparing DALK versus penetrating keratoplasty, there's a significant advantage, as you would expect, to DALK. So at 1 year, they saw about a 13% endothelial cell loss patients having DALK compared to 27.7% cell loss in patients having penetrating keratoplasty. What if we follow these patients further out, let's say to 2 years? Well, we have 2-year data. Again, patients having DALK. Here we see the preoperative, 6 months, 12 months, 18 and 24 months. And at 24 months, they found a 7% cell loss compared to preoperative endothelial cell densities. How does this compare to penetrating keratoplasty? Well, we can look at data from the cornea donor study, patients having penetrating keratoplasty. At the 2-year time point, cell loss being either 31% or 44%, depending on the age of the donor cornea. So obviously, don't have to have a statistician in the room to tell you that's significantly higher than the 7% loss we saw in the prior study. What about going out to 5 years, looking at cell loss? Again, here we're looking at 5-year data, penetrating keratoplasty, 50% cell loss. DALK, 22.3%. Again, varies depending on whether the patient's had a big bubble or a manual dissection. But a significant difference with a p-value, as you see listed there. So if you plot this out on a Kaplan-Meier survival curve, looking at graft survival on the y-axis, postoperative time points on the x-axis, here in the dotted line we see the DALK group, the solid line penetrating keratoplasty group. What this tells us is your average penetrating keratoplasty, based on this study, will have a mean graft survival of about 17 years. I have to tell you the truth. I've only been doing corneal transplants at Jules Stein for about 11 years now, but if I get 17 years out of a graft, that's pretty good for me, I think. But compare that to DALK. Mean graft survival with DALK, 49 years. Again, so for those of you who answered that question, you're not doing DALK yet, or it's too tough for your coronaries, if you're a 30-year-old or a 25-year-old patient with keratoconus, what do you think is the type of technique that you would want performed on your eye? It's no question. If you're still not convinced, and a publication just came out in Cornea a couple months ago from Enzo's group, 660 eyes having DALK. 660 eyes, huge series of eyes looking at long-term graft survival. Look at the units here on the y-axis. This is survival, and this is the attrition over time. Average follow-up in this series was 4.5 years. So the graft survival in this series was 99.3% in eyes having DALK. Again, this, I think, is the most compelling argument why everybody in this room who does transplants should be performing DALK for appropriate patients in your practice. So in conclusion, as far as the investment side of things, as far as the expense, negligible instrument costs. I'll buy you the instruments. Cheap. Lower reimbursement, again, unless you get creative as far as how you code these procedures, which I've had to do. Time and effort. It does take more OR time. Our nurses sort of sigh when they see that I've got a couple DALKs scheduled. It's like the Snickers commercial, you know, not going anywhere for a while. Aldave's doing some DALKs, so everybody just get comfortable. We're going to be here, especially if I don't get a big bubble. But again, looking at those Kaplan-Meier survival curves, it's worth it to the patient, so I ignore the moans, put it into my earplugs, or turn up the music more like, and do what's the right thing for my patients. Definitely is more technically difficult, but like with every other procedure that we perform, we will get more facile with it the more that we perform it. The return, greater donor cornea utilization of both good and poor quality corneas, visual outcomes equivalent to penetrating keratoplasty. And again, I haven't looked at formally analyzed the data in my series, but I can tell you if you have a DALK, you have retained estimates. When you put the donor cornea on it, everybody who does DALK knows this, you don't have any distortion of the host corneal rim. Corneal rim remains nice and round. So for me, placement of sutures and tissue distribution is easier, certainly easier in a DALK case than a penetrating keratoplasty case where I'll have collapse of the host corneal rim. Postoperative complications, well, it eliminates endothelial rejection, but again, be aware that stromal rejection is higher in DALK patients. Endothelial cell loss and graft survival, significantly lower cell loss and longer graft survival in patients having DALK. Thank you very much for your attention.